session. We are going to try to move rather quickly because we have 8 presenters. Every presenter is only going to be given 5 minutes time. And I can ask all presenters to keep time. I'm just getting my alarm clock out. So we're... Can you hear me? Can people hear me now? Okay. Yes? No?
Louder.
Okay. So I'd like to start by presenting Witness Mota from Engendered Health. He's working with the Acquire Project in Tanzania to present our first abstract poster.
Good afternoon, everybody. I'm here to share experience with you on the assessment of the integration family plan in the HIV services in Tanzania. This is the work which has been done by Engendered Health and Tanzania projects, with the aim of assessing the degree of integration, identify the gaps, and look for the opportunities to strengthen the integration process. Actually, the assessment was conducted in 12 health facilities in 2 regions in Iringa and Manyara in Tanzania. It was done in October 2010, and it actually utilized the assessing integration methodology. And this methodology was adapted to fit the Tanzania context. And we were able to develop 5 tools: the facility inventory, or the facility audit, to assess the capacity of the facility to provide the services, the facility record reviews tool to collect service statistics, a client provider interaction tool, service providers interview tool, and the exit interview with clients. And as you can see, we were able to conduct facility audit to all the 12 facilities, and we were able to collect the service statistics from all the 12 facilities, and we conducted 36 observations of client-provider interactions, and 36 interviews with service providers, as well as 169 exit interviews with clients. And after this process, the facilities were rated on a 5-point scale of FP integration, ranging from FP referrals only, which was category A, to fully integrated services, which is category E. Actually, this is a kind of tool which categorizes facilities according to the method of choice of family planning. And these are the key findings. 8 out of the 12 facilities were rated level D. Means that at least all short-acting and long-acting methods were done with referral for permanent methods. And at the service unit level, only condoms were readily available at non-FP units, with one exception, and rating most of the non-family planning units level A. And in the case of providers, the providers were generally positive about service integration, and they reported that FP uptake had increased. However, they perceived the provision of integrated service as time-consuming. Among those who received FP counseling, 76 were offered a method, of which 50% of them received their method of choice. Stockouts were the most common reason that clients did not receive their method of choice. And HIV testing and counseling were provided to clients attending family planning clinic. Thank you.
Thank you very much for that. I'm sorry, I neglected to introduce myself. My name is Dr. Sierra Washington. I'm in the Division of Family Planning and Global Health at Einstein College of Medicine. And so we're going to move right into our second presentation by Mrs. Ana Jacinto. She does monitoring and evaluation for Pathfinder International. She's going to present some findings from Mozambique.
Hello, good afternoon. So I'm presenting the proposal about increased IUD injectable use to integrated service provision as one of the across 4 provinces of Mozambique. So, the ESD Family Planning Initiative is a USAID-funded 4-year project that is being implemented in 4 provinces in Mozambique and in 16 districts. The project aim is to assist the Ministry of Health to integrate family planning services into existing primary health care and HIV services. And the project supports the public health system capacity building, service delivery and quality improvement, and community participation. So between July and September 2011, 760 health providers received a comprehensive training, followed by on-job training, mentoring, and supervision visits by project and Ministry of Health staff. Also, since the beginning of the project, we have been gathering routine data collected using the MTS service. And we also assess the knowledge of health providers by in-depth interviews during the mentoring visits that were held after the training in 2 provinces. For the results, since the beginning of the project and after the training, we have seen that the CIP for IVD increased from 1,344 to 2,336, and injectable, the depo-provera increased from 4,992 to 8,630. The data I'm presenting here is for the interview of only 15 health providers, and of those 15 health providers, 60 had never inserted an IVD before the training, and all said that the training was very important to improve their knowledge, practice, skills, and FP awareness. One province showed that the project supported health facilities inserted 376% more IVDs than those not supported by the project. And on average, over the course of the project interventions, the use of depo-provera and IVD increased by 72% and 32% respectively in all project facilities in the 4 provinces. We are talking about 152 health facilities. So if you can see here, I'm going to show you the next one. We have the data collected from AMH services before the training and after the training, and you can see the increase. The blue line is districts where the project is being implemented, and the red line is the data from the health facilities where the project is not being implemented, the districts. This is for IUD, and then for the depo-provera injection as well. So, thank you.
Thank you very much. Our next presenter is Dr. Paul Nantareva. He's a study coordinator for IDRC in Tororo, Uganda, in collaboration with UCSF.
Good afternoon, ladies and gentlemen. I'm here to present an abstract as regards adherence to and effectiveness of ban-integrated contraception, HIV care module in an open-label randomized control trial, amongst breastfeeding HIV-positive women. And this study is currently ongoing in Tororo, Uganda. And we looked at a secondary analysis of this randomized control trial, comparing women on efavirenz and those on Retinova among pregnant and lactating HIV-positive women. And this is broadly known as the PROMOTE studies. We are basically focusing on HIV and malaria. We did contraception counseling during pregnancy and postpartum, and we had options available to the participants, including sterilization, the IUD, the depo, and the implant, together with the oral contraceptives and condoms. Our objective was to estimate the adherence to and effectiveness of contraception among these HIV-positive women postpartum. So we defined adherence as uptake of a method by 12 weeks postpartum, and we looked at the effectiveness as uninitiated pregnancy during any point postpartum. We had 254 participants of 327 who had made 12 weeks postpartum, and that's about 73.2%. And the overall pregnancy incidence, we had 3 mothers who had a positive HCG test, and these were participants who had fetal demise and neonatal demise at the index pregnancies, and they were not using any active method of contraception. So the overall contraception uptake in this group was 78.6%, and this is by 12 weeks postpartum. And then looking at the figure with the contraception adherence amongst women at 12 weeks postpartum, the key word here being 12 weeks postpartum, we noted that the commonest method being default amongst these participants, with only one woman taking up the oral contraceptive pills. And looking at the conclusions, we noted a high uptake amongst this group compared to the Ugandan average of about 15.4%, and with default being the most popular method. Now there is conflicting data as regards transmission and disease progression, as regards to participants or women who are HIV positive but ARV naive, and we wanted to suggest to the members in this conference that additional research needs to be done to try and evaluate the transmission and disease progression amongst HIV positive participants who are currently taking ARVs. Thank you.
Thank you very much. Our next presenter is Divya Bajpai. She works at the International AIDS Alliance and is a senior advisor for sexual and reproductive health.
Good evening or afternoon, everybody. I'm going to be presenting on an assessment tool which the HIV/AIDS Alliance developed for Mary Stokes International. It's part of our partnership with them under the USAID-funded Sept project. I'd like to acknowledge colleagues from MSI as well as from the Alliance who helped with this presentation and bring this together. I'll be talking about this tool which has been developed to assess the readiness, quality and level of HIV integration into MSI services. So briefly, in terms of the methods, we reviewed existing tools and literature which have been discussed during this conference, such as the AIM tool, the Rapid Assessment tool, as well as other tools developed by the AIDS Alliance and MSI and others. The tool was then piloted last year with MSI offices in Zambia and Tanzania, and we covered 12 of their family planning clinics, both static clinics and outreach camps. The tool is fairly comprehensive and it covers readiness, the type and level of integration, as well as the quality of some of the services. From this, we were able to develop a minimum package of integrated services to recommend to Mary Stokes International. That included entry point services as well as services to integrate. Those included family planning, safer sex counselling, which covers dual protection messages, condom demonstration and supply, STI detection and treatment, HIV testing and counselling, as well as services and counselling for gender-based violence and relationship counselling. Following the pilots, we developed an integration framework for Mary Stokes to consider, following 3 stages. The first stage is for any MSI clinic or program anywhere in the world, and that is basic integration, where the minimum package would include signs of facility, which lists the available services. The provider raises the issue of STIs and HIV routinely with all clients, whatever their entry point. Posters and leaflets, as well as dual protection promoted for the services, and that condoms are visible and freely available at all facilities. The second stage was about some further integration, which is in addition to the basic integration package, to actually offer HIV testing and STI services to all clients and providers, and provided either directly through referral. And the third, which is comprehensive services provided through referral on site, is in addition to the above, to provide the minimum package services that I mentioned in the previous slide. In terms of results from the 2 pilots that we did in Tanzania and Zambia, both MSI programs provided well-established family planning and SRH services in a range of static and mobile sites, and they are certainly committed to integrating HIV. And the HIV services are provided through different entry points, but not consistently across all SRH services that they provide. And in addition, the knowledge, policy and clinical practice that MSI services are providing in relation to integration are highly variable, and they also vary in terms of quality as well. So following an action plan which is part of this tool, the MSI staff as well as ourselves agreed that with adjustments to their focus, as well as looking at additional funding for monitoring and training purposes, that MSI programs are highly suitable HIV and SRH integration. Thank you.
Thank you. Next we are going to hear from Dr. Heidi Reynolds. She's at UNC Chapel Hill and with the Measure Evaluation in Ethiopia.
Thank you. Good afternoon, everybody. I am presenting on using organizational networks to improve integration and coordination. I'd like to acknowledge my co-authors at the University of North Carolina and the Measure Evaluation Project, as well as our collaborators in Ethiopia with FHI 360. Organizational networks are grounded in social network analysis. So you all are probably have seen at some point or another those very beautiful spiderweb-looking graphs of sexual social networks, and this is applying social network analysis to organizations to see how they work together or not. As you all know, people living with HIV have many health needs. They may need care and support, palliative care, access to nutrition, supplements. They may need TB screening and treatment. So all of their needs are going to be met by different organizations who may or may not be working together. They may or may not know that there are other organizations working in their communities trying to address the needs of people living with HIV. So what we have done in Ethiopia is use an organizational network approach to understand how organizations are working to get together to achieve program objectives, meet clients' needs, and reduce duplication or fill gaps. And so what we did is we took two sub-cities in Addis Ababa. There are 10 sub-cities in Addis Ababa. They're not geographically connected, so we had some space in there. And we used a snowball approach to identify all organizations in these two sub-cities providing HIV care and treatment and or family planning to women living with HIV ages 15 to 49, 18 to 49. And so then we conducted, so we had a census of all these organizations in the two sub-cities. And then we conducted organizational interviews with representatives from these organizations to find out how they were working together or not with other organizations to improve coordination and integration services. We collected data on exchanges of information, whether they were exchanging information with other organizations, whether they were exchanging resources, and whether they were exchanging clients. In other words, were they making referrals to other organizations? And then we also conducted client interviews with home-based care clients to find out how they were perceiving the coordination of care by the organizations. So I didn't put too many pretty pictures in this presentation because I really want you to go look at my poster. But basically what we found is that there were a few referrals between organizations. We found a lot of gaps where organizations, clients needed services, but they weren't connecting with other organizations that needed those services. And we found that clients' needs focus mainly on the need for social services like job training or housing support, and they have pretty low ART adherence. But again, there's more information next door. In the meantime, that was the baseline data collection, and we have since conducted organizational network strengthening activities with these organizations, with representatives, using a leadership development approach, and have found that the organizations are very, very interested in connecting with other organizations. These are not networks that exist normally. These organizations didn't necessarily know they were actually part of a network, and we've created a network of organizations providing family planning and or HIV care and treatment to people living with HIV in these sub-cities. And so the next step, which is going to happen next month, is we're going to do a post-test, a post-intervention to find out how referrals have improved, and also see again whether clients can perceive differences in the organization of the networks, and whether they're getting more connected with their services that they need. And in my last 30 seconds, I want to say that we feel like this has two potential applications. This is new, something we're testing. It's not really been tried elsewhere, especially in developing countries for HIV. We think it could be a program assessment, and where it could be done to identify gaps and help improve referrals and coordination between organizations, so as a program strengthening tool, or it could be done for an evaluation purpose where it's a much more quantitative tool. You use social network analysis and sophisticated statistical techniques to put some real statistics and numbers around how well your organization, your network is working together. And I'm out of time, but that's why you have to go see the poster. Okay.
Thank you very much, Dr. Reynolds. So in the spirit of audience participation, I'm calling up Dr. Dan Grossman from IBIS and UCSF to present on behalf of Dr. Sarah Newman with her research from cases.
Thank you very much. So the research I'm presenting today for Sarah Newman is a collaboration among UCSF, IBIS, FACES, and the Kennedy Medical Research Institute. Certainly there's other evidence suggesting that imbalances in perceptions of relationship power and gender equity among men and women can impact women's sexual and reproductive health, but there's really no data looking at whether integrating family planning into HIV care and treatment impacts perceptions of gender equity and relationship power. And so the objective of this research was to look at whether integrated family planning into HIV care and treatment at public sector clinics has an impact on gender equity and relationship power among HIV-infected men and women. So for those of you who heard some of the other presentations from the cluster randomized trial, these data come from our N-line cross-sectional survey that was performed at 18 public sector sites, 12 of which participated received an intervention where family planning services were integrated into HIV care and treatment, and there were 6 control sites. And again, this cross-sectional survey was performed after approximately 1 year of having received the intervention. The cross-sectional survey included approximately 500 women and 500 men, and the questions that were analyzed in this analysis came from the Gender Relations Scale, which was developed from the Sexual and Reproductive Power Scale and the Gender Equitable Male Scale, which were published, validated scales looking at these measures. Some of the sample items, for example, on the Gender Equity Scale, which tries to assess fairness and justice in the distribution of benefits and responsibilities between women and men. Some of the items include things like it is a woman's responsibility to avoid getting pregnant. A man and woman should decide together what type of contraceptive to use. And then the relationship power measures, that's trying to look at the ability of one partner to control actions within a relationship. Some of the measures that, the questions that go into that measure are statements that the participants can either agree or disagree with. I feel comfortable discussing family planning with my partner. My partner dictates who I spend time with, things like that. The analysis was similar to the other analyses that we presented. There were multivariable regression analyses to look at differences in attitudes by study intervention, and we used generalized estimating equations to account for clustering by site. In terms of the participant characteristics, we actually presented some of that yesterday, but there were no differences that, and which we also talked about yesterday, was that women in integrated sites reported significantly higher use of more effective family planning methods. So 60% of women had, this was again the cross-sectional survey data, 60% of women reported using a more effective method compared to 42% at control sites. So these bars, the graphs here, represent the differences on the left in mean gender equity, and on the right, relationship power scores separated by men and women. As you can see, the blue bars are for integrated sites, and the red bars are for control sites, and the key values that are up here are actually from the multivariable analysis. And as you can see, we found no differences in gender equity attitudes between women at integrated sites versus control sites. However, among men, we found that gender equity attitudes were more favorable among men who were obtaining care at integrated sites. And of note, as you can see on the right, the differences in relationship power for men and women did not reach statistical significance, but are suggestive of slightly improved power, relationship power measures at integrated sites. Also in the multivariable model for men, other factors that were associated with gender equity included higher education and lower purity. So it looks like what we can take on from this analysis is that while, at least for women, while integration may improve contraceptive use, as we also found in the testimony of this trial, it did not appear to have any impact on improving gender equitable attitudes. But we did see that, at least in this analysis, that integration did appear to improve gender equitable attitudes. So really, I think this is an area that deserves further research. We have a lot of presenters looking at how to engage men and try to improve gender equity in relationships in this context. We really think that longitudinal couple-level research is needed to explore whether improvements in gender equitable attitudes among HIV-infected men actually has an impact on improving contraceptive uptake and use of female partners. Thanks.
Thank you very much. Our next presenter is Kamboso Nzekezeke. He's a data consultant with Guttmacher Institute and the University of Abuja College of Medicine in Nigeria, and will be presenting data from Zambia and Nigeria. So we're experiencing a few technical complications. So in the spirit of efficiency, perhaps we can take one or two questions on the first 6 presentations now, and we'll take questions on the following 3 presentations after. No questions? Okay. We'll move on.
Sorry for the glitch. So this is part of a large-scale study looking at HIV and AIDS patients. It's being done in Zambia and Nigeria, started in 2009, funded by the U.S. National Institute of Health, and then led by the Guttmacher Institute. And what I'm presenting here is just something we got from the analysis from the data we collected from health facilities. And we are looking at the perceptions of healthcare providers and their patients towards childbearing and pregnancy. So the study involved 43 health facilities in 3 provinces in Zambia and 49 facilities in 4 states in Nigeria. And in Zambia we had 151 HIV positive women, in Nigeria 206. And these were aged 18 to 49 years. The healthcare providers were 107 in Zambia and 147 in Nigeria. And the facilities where they were recruited from are the same ones where we recruited the persons living with HIV and AIDS. So basically these were patients with the same healthcare providers. The idea was to see whether healthcare providers Yeah, so the key findings is that there's a lot of support for childbearing and for abortion. I presented in the morning where I showed that people with HIV, if they became pregnant, were more likely to abort than to continue with the pregnancy. So, in terms of views, actually both healthcare providers and women with HIV support continuation of the pregnancy than to abort. And this slide there shows just how different these margins are. The red bars are for the support, the white bars for non-support. And you have the women in Nigeria there and the women in Zambia. Women in Nigeria are more likely to give support than women in Zambia, but both groups will give the support. Same for providers. And then on childbearing, there's more support if you have no children or you have fewer children. And if you are using art effectively than if you are not using art effectively. So both groups have the same perception. More details, please go. Thanks a lot.
Thank you very much. Next, we will hear from Lama Katema. He's with Management Science Health in Ethiopia.
Thank you, Mr. Chairman. My presentation is about the area we are taking the linkage in HIV care services among pregnant women in health centers in Ethiopia. So if I tell you the background of Ethiopia, it's one of the populous nations with relatively low prevalence rate of HIV, but it is acute. If you take the number, absolute number, the burden is high, and European TCT coverage is not as satisfactory because the broader geographic coverage of the country. And recently we developed the TCT plan, and also we adopted option B plus in August 2012 because we think that it is going to decrease the habits that we are encountering in implementing the TCT. So there was a program which covered 4 years. The program covered a significant region in the country, and when we look at all the programs, we have seen that the uptake of HIV testing and counseling was high, but the ARV uptake was low. Nationally, it was 40%, when the program actually was 45%. But so we thought that what should be the cause of this low uptake in program and supported facilities, despite the number of supported that we are going to provide. So this research answered the following question: why are ARV uptake and clinical so low, and how are we going to implement a mechanism to improve uptake and linkage? So we did a register review of when from the numbers we selected high patient load health centers, and we compared the reported data. And also we looked at unlimited HIV pregnant women were traced and invited for interview. So if you look at the reported and the reported data, there is a difference. The reported show low uptake and also linkage, while when we go and look at the reported data, it shows a better performance. So if you look at the total number that we have seen, we were able to access 890 women, and the report told us that it was 60% were linked. But when we look at the system, we have found that 74% were actually linked to the service. So most of the low ARV coverage was due to the reported data, and this corroborates the fact that we need to look at the whole system of data collection and reporting when we measure results. So we have certain challenges that we are, because of the option B class, we are going to approach, are we going to approach one-stop shop approach, or which one is going to be feasible? Will B, because the B class is that in the take of MTS, will B class include a complicated adherence issue we are going to look when we implement the option B approach for MTCT. I think this is an important message, so I think this is what I'm going to present. So way forward is we promote the coverage for ANC and assisted delivery. We are going to pilot the integration of ART and the ANC, and also we are going to conduct research from B class, which is going to tell us about the linkage and also the adherence issue later on. So the cross-cutting issue is, as you know, the partnership and also promote the use of research and the data for evidence-based decision. So when we look at integration, then we need to look at what value of evidences we are using to make the impact is the take-home message that we can take from this presentation. Thank you.
Thank you very much, Mr. Kandama. Our next presenter is Austin Njutue. I'm sorry. Perhaps you can say your name better than I. He's from Management Sciences and Health from Nigeria as well.
Thank you very much. I think I have the privilege and honor of being the last presenter, so I won't take much of your time. Basically, this is an offshoot of this baseline assessment that we did, and we looked at knowledge and utilization of reproductive health services among pregnant positive clients that enrolled in the MSH ProAct project in Nigeria, in 3 facilities, 2 secondary and 1 primary healthcare facility. And I think just was interesting because again, over the last day and a half, there's a lot of discussions around client-centered care. So basically, we administered questionnaires to 39 HIV positive women who were enrolled to assess their knowledge and utilization of maternal and child health reproductive health services in these 3 facilities, Rural Hospital in Lapai, General Hospital Leader, and the Comprehensive Health Center in Leader. And these facilities offer a wide range of sexual and reproductive health services as well as HIV, which MSH supports. In terms of results, we realized that most of these clients were quite knowledgeable about the availability of these services. For instance, they were aware that there were family planning services in those facilities, but in terms of utilization, it was really poor. When you compare, they had 54% of them were quite knowledgeable, but in terms of utilization, we had about 8%. And again, this was across all the service areas that we looked at, when compared to their knowledge and in terms of how they utilize the services over a period of time. So basically, in conclusion, knowledge of family planning and reproductive health services didn't quite translate to utilization, despite awareness to the many of the respondents. Again, this is very critical as we're talking about integration and trying to adapt or implement several models. We have to really put the client in perspective in planning most of the interventions. Thank you.
Thank you for a very speedy presentation, and I'd like to thank all of my presenters for keeping time. I think we might get out of here in a timely fashion. Let me open the field to questions from any of the audience members regarding any of the poster presentations, clarifications, or comments.